Well, thank you everyone for joining our ACNI webinar, where we have a host of experts talk about areas that are of high interest to our families and our members in our community. I only have a few slides. Again, mute your lines during the um, when Dr. Tsemberis is talking. You can always either raise your hand or put a question in the chat, and we will just pause and ask questions so it's more interactive. Just to introduce our board, here are our board of directors. I won't read to you guys. I know that everyone's capable of reading. And then again, what we're going to speak about tonight is housing first, not housing only. For whatever reason, people have the misunderstanding of housing first means just put people in a house, and that's not what it means. But somehow it's gotten to that point. So Dr. Tsemberis is a clinical psychologist that developed the Housing First program to stem homelessness for people with severe mental illness and addiction issues. And I will now turn it over to Dr. Tsemberis. I will allow him to share, but we're really excited because he is a well-known national expert on housing first.
Thank you. Thank you very much, Lori. And good evening, everyone. A pleasure to be with you. I will try and share my slides here. Just trying to get the full screen view. That's it? No, it's up here somewhere.
You can go into view and go into presenter mode, or I can't see the bottom of your screen.
I'm sorry?
I was going to say you can go into view and go into presenter mode.
Okay. Screening, stop share. View. Sorry. Oh, here. Okay. Sorry. Trying to find the right thumbnail. Show small. Okay. Are you seeing the slide at all?
Yes. Everyone
Okay.
else, are you guys seeing the slide?
And the only thing is you're seeing the ones on the left-hand side also, right? And I can't quite figure out how to get rid of those, but let's start with that, and that'll be fine if that's okay with you.
Okay.
Okay, so my topic is about housing first, as Lori mentioned, and you know, I was going to talk for about half an hour or so, and then but as she said, at any point you want to ask questions or make comments about any of this, I'm totally happy to stop and discuss it. You know, we're a small group and we could have a nice chat about it. So one of the things I guess that's happened, you know, over the years about addressing homelessness is that this Housing First program has gotten to be quite well known and widely implemented. But in the course of that time, as the program has expanded and agencies, federal agencies like Housing and Urban Development are insisting that programs for people who are homeless and have a disability use a Housing First model, everyone has kind of jumped on the bandwagon and calls whatever program that they're doing that relates to homelessness or addressing homelessness for people with disabilities, they call it a Housing First program, because you have to check the box that you're doing a Housing First program or your score on the funding criteria would be less. So you know, you could think sometimes that policy is driven by science and evidence, but often it's driven by, what is being funded. So I guess let me start with the first thing about Housing First that's not well known, which is that Housing First is actually not about housing. Okay, so Housing First is not about housing. Housing First is actually about psychiatric rehabilitation. The way that the program started many years ago, almost 3 decades now, was with an NIMH grant that the co-PIs on that grant were Bill Anthony from Boston University, myself, and someone also at the State Office of Mental Health named David Shern. And what we were trying to do with this NIMH grant was to introduce the idea of psychiatric rehabilitation to people who were not ordinarily coming into clinics for treatment, but were actually on the street with severe mental illness. And our goal was to use the psych rehab approach, which to put it very quickly, is very consumer friendly, client driven, tries to engage people from where they are and move them to the immediate next steps of where they'd like to go. Now, it's not that we wouldn't prefer to just do a diagnosis and tell people where to go and have them follow that prescription, but it doesn't work that way. As you well know, people have to do better if they're participating in their treatment plan. And so my first disappointment about getting this grant was that Bill Anthony began to explain that this is about client choice and it's not about housing. I was working at the time doing street outreach for this group, and I was desperate to get them inside. And I thought, oh, we got a grant, we're going to get people housed. He says, no, we're not going to get anybody housed unless they want to be housed. If people want treatment, we'll take them to treatment. If they want, to go to their families, or if they want to go address their medical problems, we're going to take it from where the client is. And this is a lesson that I try to convey both in terms of my own personal experience and also to say something about the kind of staff that would do well working in a Housing First program are people who are willing to listen to another person and to be changed by what they hear from that person. That's what actual client-driven means. It means that you really are there to listen and put yourself in a position that if the person is telling you that this is their priority, that you're willing to change your point of view and go with their point of view. That's not an easy thing to do, and it's not for everybody. So, for staff that like to have a lot of control, or being out of control makes them anxious, they like, policies and procedures. They like to have everybody in a supervised building, and they go home at 5 and there's someone else taking the shift and your job is over. And there isn't, calls, on-call, weekends, chaos. If you don't like that kind of work, I would encourage people not to work in Housing First programs, because Housing First is very messy and kind of difficult to run because it runs on other people's time, not your time. So that's the first thing about Housing First. Housing First is all about trying to implement a recovery-oriented model for people who are experiencing homelessness and have a severe mental illness. So what?
Let me
Oh,
jump in
please.
real quick.
Yeah.
Since I'm not sharing, I have no control. I can't mute people. I can't see my chat, and I can't monitor. So you'll have to monitor the chat. Because in my window, all I see is yours. So I'm just letting
Okay.
you know so you can open your chat and see that as well. But
Okay,
I
all
mean,
right.
I really
You know, I have
see
to
what
figure
you're
this
saying.
thing out because does someone know what the top of the bar looks like? I know there's a little thing here that I need to press to put the thing in slide mode and see the rest of the bar, and I haven't quite achieved that yet. So you are screen sharing, new share, maybe here? No, not new
That shouldn't
share.
be it. If it's in
Oh, here's the
PowerPoint,
chat. I see the chat. I see
yeah,
the chat.
okay,
Okay, good.
good.
I'm good.
If
At
are you on a
at
Mac
the bottom of
or a
your
PC?
screen, you can see
Yeah.
next to the Zoom on the very bottom right-hand side where it says
Thank you.
92% or something.
Yeah.
Next
Okay.
to that, there's a little icon that looks like a
Next to the
little,
chat.
It looks
I
like
see.
a little projector.
Yeah.
on
I-
your whatever your PowerPoint is.
Yeah, I see the chat now. I'm good. No one has written anything. But also, I encourage you to just unmute and please, interrupt. It's like there's 20 of us here. It's like just imagine we're sitting at where would we be sitting comfortably outside at someone's backyard, I suppose, at this time of day. Anyway, so that's the first thing. It's all about people and it's not about housing. The way it got to be about housing, I'll get to in a minute. But, Bill Anthony was about changing the system, recovery-oriented systems. And I'm not going to go into the psych rehab approach. I imagine many of you have heard it over time. And, this was in the 90s. He was writing about recovery, and recovery is it's a big topic now. And, some of the things that, it wasn't recovery like pie in the sky recovery. He was strong on the idea of people having a choice in their way of whether it was housing or employment or whatever the next step was. He said correctly, because we've all known this, and especially this group knows this, that you can be in recovery or recovering and still have psychiatric symptoms. It's not like we're looking for a symptom-free life. It's like we're looking for a life that is a life of meaning, even while you're managing a mental illness. It's a practical life. I mean, just like we all live with anxieties and ups and downs of depression, but we have a life, and it's not so different. The criteria for recovery is not perfection, it's managing a life beyond the symptoms. And he had also observed that, when people were getting hospitalized for years at the time, that he said that recovery from the consequences of the illness, over medicated, being in an institutional setting where you don't make any decisions and you become debilitated, is sometimes more difficult than recovering from the illness itself. So that's Anthony, that's psych rehab. That is one of the cornerstones of Housing First. The others are, having a sort of a social justice perspective, housing as a human right, and working with not only Anthony, but people like Judy Chamberlain and people who were advocating for voice in the mental health system, in the treatment plan, in the planning of the program, and in the mental health system at large. This isn't about homelessness, it's really about mental illness and homelessness, but I just include this slide here to let you know that homelessness is not a thing like a disease, otherwise it would be evenly distributed. Homelessness is really the result of economic prosperity. This is why we haven't ended it, because we're very prosperous and we are constantly building and gentrifying neighborhoods, and we are doing so well, but not all of us. So some of us are doing extraordinarily well, and others of us are like hanging in there, and some of us not well at all. And as things get gentrified, the people who are on disability income or have a disability or an SSI, and if they happen to lose their housing in one of those renovations, with the rent check you get, or with a disability check that you get on a monthly basis, you are priced out of the real estate market forever. You will never be able to put together a month's rent and a month's security deposit. So what this map shows you is that in those states where the economy is booming, especially the real estate economy is booming, The numbers of people who are homeless per capita is much higher than in the states where it's not. It's absolutely, homelessness is really a byproduct of real estate development progress. You know, they go hand in hand. In fact, we could solve this thing very quickly if we put a 0.5% contribution to homeless services on every real estate closing, commercial and private. We would generate the billions of dollars we need on an ongoing basis to build the affordable housing that is not there right now for people. That's the thing I find actually most frustrating about this whole business, which is we can solve this if we wanted to. We're just choosing not to. And across the different states, there are also different ways that homeless people are seen. The predominant narrative, you know, that you get in the media, and quite purposeful, you know, and deliberate, because you don't want to point to real estate or system failures or lack of services. That's a little too self-critical. So you point to the people who are out there and you say, well, they're not taking care of their mental illness, you know, they have an addiction, lack motivation. The majority of the press around homelessness equates homelessness with personal attributions, bad choices, and so on. And they don't look at these systemic factors, you know, the fact that 5 times in some places, everywhere, in every state, the disproportionate number of people who are minority are homeless, African American primarily. If you go down the coast, like New York, Washington, Atlanta, for example, the percentage of people who are homeless, individuals, not families, individuals, about 80% are African American. So this is not a uniformly across the board, either economically or racially or otherwise. But we talk about homelessness like it's an individual problem. And because we talk about it in different ways, we also address it in different ways. I mean, on the one hand, we have the social service approach, outreach, you know, shelter and so on. And then we have the law enforcement approach, and states balance or play with those back and forth, depending on who's the governor or who's the mayor. And it's a kind of a political football at the cost of homelessness. Neither of them, you know, particularly effective, but because we don't have a unified, consistent, community-wide approach, we continue to have the problem because we're going this way one year and then the other way another year, and it will take a multi-year effort with a consistent plan to end it. And I'll give you examples where it has been ended, and that's exactly what it takes. The current system resembles what an inpatient unit is like. You know, the current system for providing people with mental illness housing services. Early on, we decided that it was a personal issue and people needed to be treated in order to get housed. Somehow they have fallen out of housing because of their psychiatric disabilities. That's true in some cases, but that's most likely because they didn't have the right supports. Most people fall out because of economic reasons, and then because they have these disabilities, there's no way they're getting back in. So it looks like they're there because of their disability. And what we've done is we've created a massive system of shelter, you know, sobriety, transitional housing to permanent housing. Eventually, that's still the predominant system. And it works for about 40% of the people that enter into it. We've done studies now comparing this system to the Housing First system. So we know it's not, well, you know, I'm not giving you opinions, I'm giving you data from 26 actually randomized controlled trial studies that were reported by the CDC recently. So what happens to the 50 or 60% that can't or won't make it through that system of having to comply with the curfews of the shelter or the sobriety rules or, or the treatment rules? Is they keep going in and out of shelter, they keep getting arrested, or they go to the hospital for a short time and they're back out on the street. You know the drill. And this is the group this group, the group that failed the traditional system, that's the group that Housing First is addressing. We targeted that group because we knew going up the stairs was just not an option for them. We had to try something else. And what we tried was, this psych rehab thing. So, well, let's try talking to people. Maybe they have a better idea about what they would like to do. That's how we got to Housing First, because we didn't have housing at the forefront. We had client choice and conversation at the forefront. This is a very early picture of me talking to a guy on the street about what he wanted. It was a very difficult conversation. He had a lot of ideas, and we smoked a couple of cigarettes. And when I look at that picture, I think what I wouldn't give to be able to squat down for a half an hour like that with those knees, Anyway, that's a different story. But I was doing involuntary commitment at that time. People who were on the street and met the criteria for danger to self or others would be taken to Bellevue Hospital by the police. And then, some of them we didn't see, but unfortunately, many of them were back on the street 20 days later, and then all over again. And that sort of desperation and the futility of that failure is what led us to we got to try something else. We got to try asking people, which means that we had to shift our way of thinking about things, let's ask people, because people have strong opinions when you actually give them the opportunity to express themselves. So we went from telling to listening, and we went from having the person included in the plan. And that is how we got to Housing First. Because what people said when we gave them the opportunity is isn't it obvious? I need a place to live. I need a place to live. I'm on the street. I don't know if I'm going to be alive tomorrow. I don't know where to eat. I don't know where to go to the bathroom. I don't know when I'm going to get arrested next. I don't know where to put my stuff. I'm desperate. I was the uppermost in everybody's mind, regardless of symptoms, use, or anything else. So it was the client's choice to be in Housing First. And that's how it got that sort of shorthand, Housing First. This is what you guys do. You put people in housing. Yes, we do, if they want to be. And 99%, 95%, that's what they wanted. And that's where we are. But that was just the beginning. The entry point to Housing First is not the apartment. The entry point to Housing First is the interdisciplinary team, the ACT team, or the intensive case management team. It's the program piece that's the admission point. Person says housing, we take them to housing. Person says benefits, we take them to benefits. If the person loses the apartment, they don't lose the service. The service stays with them throughout their disruptions in housing. If the apartment doesn't work and they want to go somewhere more supervised, we take them there. If they want to go to detox, if they're hospitalized because they become psychotic after they're housed, or they become withdrawn or paranoid and they don't trust anyone, we'll hospitalize people involuntarily, but we'll visit them in the hospital and we'll bring them back home. So the housing is not connected to the services that way. So I thought you lose the apartment, you're out of the program. We'll just do the next thing that you need in order for us to continue working with you towards recovery. The goal of the program is not ending homelessness. The goal of the program is much more ambitious. It's about recovery. Housing, of course, is a necessary first step.
Okay, so I know maybe where you're at, that can work at times, but in Arizona, if you're in a birth and you have to go to the hospital to be readmitted, they only hold the bed for a very short period of time. It may be 24 hours. If you're lucky, it could be up to 72. But if your body isn't in that bed, then they free it up. And they open it up for someone else that needs it. So
right, because the system is set up that the providers of the housing need to have the beds filled to make money. That's not the model we're talking about here. We're talking about people having a voucher or shelter plus care or some other kind of rent subsidy where people have a lease. Most people in these programs would prefer, we would take them to a community residence if they wanted, but most people would prefer to have a place of their own. And so just like the rest of us, if you get sick and you go to the hospital for a few days, as long as your rent is paid, it's still your apartment, So I know there's all kinds of limitations from a policy perspective and all of that. I'm just describing the model like that we could be working towards, perhaps, if it's not already there. You know what I mean?
There is permanent supportive housing where you pay a portion and you sign a lease. We have
Right.
all levels of that. We have people that are specialists on the call, such as Jennifer Page and David Bridge
Okay.
and Charles Sullivan. They're all experts in this in Arizona.
Oh, good.
I think there's a difference between if you're in behavioral treatment facility, so you have to be involved in treatment. There's also a problem if you're in scattered housing and you're very ill and living alone. Even if you have an ACT team, they don't live with you, they come by. So if you're screaming at your neighbors or banging on walls or causing havoc, you're going to get evicted.
Right, that's right. And, so maybe for some people, I mean, I haven't gone to the outcomes. This works 80% of the time, 80, sometimes 90 if it's done well. But there's a group of people that it doesn't work for because they can't manage the independence, and they need a different level of support. But we wouldn't kick them off the ACT team. The ACT team would help them find the next place.
In theory. I mean, in theory.
No, not in theory. Not in theory. I mean, if you're great, I'm talking about what is housing first. This is not housing first in theory. This is housing first when it's practiced according to program fidelity. That's what I'm talking about. These are not. This is not like a conceptual model. There are housing first programs all over the country. Now, you may have not implemented one there, in Arizona or in Phoenix. I know there's some good housing first programs in Tucson, for example, but the program is quite specific and does deliver these outcomes for people. I mean, you said there are other people on the call. Do other people have
So a
comments?
question, I have a comment. Isn't there a shortage of housing? I mean, it seems like there just aren't enough beds for the number of people that have this need. So if you're doing housing first, isn't there a national problem with housing for people with serious mental illness and a shortage of beds?
Well, let me ask you this. Isn't there a national shortage of mental health treatment programs? Isn't there a
Yes.
national shortage of hospital beds? Isn't there a national shortage of, all of the social service stuff that we need?
Yes.
Yeah. So it's no different. I'm talking about these programs are typically, it depends on how you set it up. Sometimes one agency sets up a program, serves 100 people. There's enough housing for that. We're not talking about huge numbers of people who actually meet the criteria for these housing first programs. I'm not talking here about ending homelessness for everybody. Most people who are homeless, like 80%, don't need an ACT team. They need just a few months rent. They need some subsidy. You know what I mean? We don't have enough housing to end homelessness, but I think there's enough housing that could end chronic homelessness or homelessness for people who have severe mental illness. It's getting increasingly more difficult to find. And if we have this conversation 5 years from now, there probably won't be, because the benefits will be even more out of touch with where the real estate market is. But, for me, these are like practical issues. I'm a psychologist. I'm not a real estate person. For me, the most interesting thing is if we give people with mental illness the right housing and supports, can they have a better quality of life that looks more like recovery? That's the thing that I care about. So if we can demonstrate we can do that, then bringing the resources to the table and having advocacy at the local level, whether it's the mayor or the governor or the Department of Mental Health or your local, managed care entities, then we know what to advocate for and what we need. But to me, the useful thing about this is to know that pretty much we can house anybody. There's no reason that we can't house people with the right housing and supports. No one should be out there because we know how to end it. And it doesn't have to be homeless too. I mean, we could house anyone with severe mental illness, I would argue. Homelessness just adds another challenge to it,
Dr. Sam,
Yes.
I'm wondering about the population of the sickest people in psychosis with anosognosia. I know in my state of California, families cannot get their adult children into care because, well, the number one barrier is anosognosia. And because of our laws, the LPS system in our state, it's extremely hard to get compassionate involuntary care, to get a person on the road to recovery, whatever that looks like for the individual, and to be able to get into housing and take care of their everyday living needs with supports. I totally support this recovery model, but there is a segment of the population of the sickest that even this wonderful model of giving choices, I just don't see how that can work for people whose decision-making capacity has been severely compromised by their psychosis.
Yeah, I'm sorry if I've given you the impression that this is for everybody.
No,
There are exceptions to every model, and I'm saying this model in general, for people who are homeless and have severe mental illness, schizophrenia and bipolar, and all of that, this works 80% of the time. So yeah, there's going to be people that, you'll have to have a different approach, maybe more regimented, maybe more structured. Like there's lots of programs that are run with some of these principles, but they're in a single site building. There's staff on site, and the building is much more supervised. And usually, if someone, let's say, tries this scattered site apartment approach, 2, 3, 4, 5 times, and it's like not working, then it's like you can't. There aren't enough landlords that you want to burn bridges with, and it's not good for the staff. It's terrible for the person. We're looking for a different kind of program. But there is a limit to choice. When it's not working, you gotta do something different. It's it's a person-centered approach. So we start out with our best foot forward, hoping for the best, and then go as far as we can with the support to maximize the person's access and ability to have as normal a life as possible, given what they're dealing with. And then we'll backtrack from there, as we go, we learn as we go.
Thank you.
The program has these principles, which I think we've covered really most of them. The ones that where people, like when I said in the beginning, people misunderstand this program. They understand choice in a way that is also not the way it's intended. But there are 2 program requirements. If the person chooses an apartment, they have to sign a lease and live with the same terms and conditions in the apartment as everybody else in that apartment. The terms and, you can't be screaming at night and having guests and all of that. You have to meet the terms and conditions of a standard lease, which also includes paying 30% of your income towards the rent. And the other mandatory part of the program is you have to agree to home visits as often as needed. That's not saying you have to be clean and sober or take a drug treatment test or even take medication, but you cannot you cannot not see us. We're not going to put someone in an apartment with these kinds of conditions and not visit them. And we visit them, and this gets to the principle 3, that the services must match the needs of the client. we visit them as often as is necessary to make sure they're doing well, or they're doing well in that apartment, that they're safe, people around them are safe, and they have something to do during the day. Where people get this wrong is they think, well, the person's choice, they told me they don't want to see anyone, so people don't come back. That's a misunderstanding of the program. And I think one of the ways that people push back on Housing First programs is that people have taken that literally to mean if a person says no, that the staff does not visit them. That's where things really fall apart, and that's a misconception. Just like, when Lori introduced this, it's like housing first, but not housing only. The services are part and parcel of it. So those are the two most important. And the service array, the intensity, people think, oh, I'm only supposed to do mental health treatment, or I'm only supposed to do addiction treatment. So if the person wants to go, for a walk in the park, where the person needs, they're shopping for something that's difficult for them to get around, they need a ride. I define the services provided as whatever it takes, not what is reimbursable by Medicaid, not what is under the Medicaid rehab option plan, whatever it takes. And the staff has to be creative enough to figure out how to bill for medical services, because we have that mandate, but the services are not defined in a narrow way. They're defined as anything the person needs. So that's really what I was going to say. I mean, I can give you, I don't think I have to say that it's a risky program. You have to be willing to, when you give people chances and that they have good and bad days, there is an element of giving people a chance to fail, which can feel scary, but if we had figured out another way to have people learn by their mistakes, I think we would do it. I think the team that's there should be a safety net so people don't fall all the way down into disaster, but it's not a program that is overly controlling, but it does allow people to make a lot of decisions about, not using how much until things get in the way. And, it's kind of like supported chances, supported real life learning in real time. That caseload ratios need to be low. I think you all can appreciate that in terms of ACT teams, that it's about assertive engagement. There's no refusing to visit. You don't want to see us today, that's okay. You're having a bad day. We're going to be back tomorrow. We'll be there. We'll be back to see you tomorrow. This program has been studied a lot. I mean, in terms of research, randomized controlled trials. This is one that was done in New York early on. This just shows, because we were focused on ending homelessness, so most of the data is around housing stability, hovers around 80% for the housing first group and around 40% for the treatment first and then housing group. That was replicated in a national study in Canada. They spent $110 million, mostly on housing subsidies and ACT team-like services in these 5 Canadian cities. They had essentially the same pattern of results that we did, about 80-40. France is a country that had a huge institutionalization system. Like everything in France had very little mental health. And when they took on this 5-city housing first program, they learned about ACT, and now they have like over 40 ACT programs, and they're reducing institutional care in France. But again, everywhere where this thing is done, it reduces homelessness tremendously. Even here, the HUD-VASH program, I'm sure some of you on the call are familiar with, 83 cities in America have ended veteran homelessness because the government has agreed to give vouchers and robust support, vouchers from HUD and robust support from the VA. So, we can do it here. My favorite current example is the city of Milwaukee. They started this about 3 years ago. And that Trojan horse thing is to say, once you start doing housing first, it starts to affect other systems in your city. So the city and the county decided to adopt housing first. They had about 200 and 300 something chronically homeless people that qualified for the Housing First program. And it was like a multi-year plan. It was led by the local housing authority that got an outreach team. They didn't rely on this coordinated entry and VI SPDAT. These are the VI SPDAT in particular is a terrible way to prioritize people. And it's getting, finally swept out of the way. It's been a disaster nationally. Anyway, what they do is they rely on their outreach clinical teams assessment to get the right people, and people homeless, people with mental illness. And the housing authority was ready to hand out vouchers. They were moving along. They were getting the business community involved. And then people were showing up. They had all of these outstanding warrants, and the housing authority couldn't issue Section 8 vouchers because if you have a charge, the district attorney got involved and started doing outreach with the outreach teams and removing the warrants from people that had them as a result of being homeless so that they could qualify for the vouchers. The thing took on momentum. The downtown business district got involved. Instead of calling the police, they called the outreach team for the Housing First program. The police call the outreach team when they're called about a homeless person, so that the whole system over these 3 years has really shifted to thinking about, we call this outreach team, there's a response and there's a solution. In this last point in time count, in the most recent point in time count, 2021, it came out just a couple of months ago, Milwaukee, a city of about 700,000, had the lowest number of homeless people in the country for cities of that size. They had 17 people who were homeless left in the whole city. So, city and county agreed, coordinated effort, all of the resources going in one direction, district attorney, police, business, faith community, the soup kitchens. When you identify someone that could qualify for this program, it's really a great example of how things can work when we have a common vision and a community unified to move in the same direction.
One question. Do you think
Yes.
that like areas like California, Arizona, Florida, places like that, it's pretty, the climate is much kinder to homelessness. It's not the same as some of the Northwestern places that are freezing at night.
Right.
And they, we've heard stories that they put people on buses and bus them to warmer climates. So do you think that
Well,
they
that's
have
that's
17?
no, that's not what they did. When you look at the data here, like I'm in Los Angeles, and they do the point in time count quite well. They don't do it one night. They do it over the course of like several weeks. Over 80% of the people who are counted outside are either right from the LA County or from a nearby county. So people aren't going, like also, I think that one of the reasons there's people on the street here, is because there isn't much of a shelter system. New York City has the same number of homeless people as Los Angeles. They both hover around 60,000. It's just that the visibility is much greater, where the weather is nicer because people can stay outside, but also New York has a vast shelter system, so people are more hidden, I would say,
We have a
Yeah.
question from Dick
Okay.
in here. What is your view? I can see now that you're not here. What is your view of involuntary commitment to a secure residential treatment facility for persons who are severely afflicted and lack insight? And I
What is
assume
your
Dick
view of
means-
involuntary commitment to secure residential treatment? I think it depends on the person. I think, like I said, I used to do involuntary treatment for years, and, we saw a lot of people on the street, and there were some people that you couldn't leave them on the street. They not only were not doing well, they're sitting, near the curb. They're going to get hit by, they were like not aware of their circumstances. We have involuntary treatment laws for a reason, that there's a point at which people need that kind of help. Absolutely. I think what you want to do when you do that, though, is to, I think much of the controversy around involuntary treatment, I think, is how the person experiences it, so that you can have someone who is kicking and screaming about going to the hospital. But what we would do, and I think that's important, the intention with which you do this and how you carry out the treatment, we would go to the hospital the next day and explain why we brought you to the hospital. We were very, very worried about you. You were on the street like this, like to demonstrate to the person that this was not some punitive act. This was an act of concern and of an intent to bring you to a safer place. And, people may be psychotic and hearing things, but they also take in a lot of information, and that kind of intentionality and consistent messaging about why you did it, I think goes a long way in not, because you don't want to rupture the relationship. We're striving for a no discharge policy. So we don't want people, like, just because we committed them involuntarily, to stop working with us, and I think if you work at it, I think you can achieve both, bring people out of danger when they need it and still continue to work with them afterwards.
I wish that was happening in San Diego, but it's not. It's absolutely not. People are just disintegrating on the streets, and you're you're obviously a very caring guy, but that's just not happening here. And our involuntary commitment laws are so stringent, families can't even get the sickest into care, even to the point like what you're saying is that when you deal with somebody like this, you want them to know that your intention is good. I totally get that. But if they're so into their psychosis and paranoia, et cetera, until they get the medical care they need to help them to bring back some of their decision-making capacity, I've seen that it doesn't work well, at least in my experience.
Yeah, no, it doesn't, it's not immediate. I mean, I'm just saying, you go when you can reach the person. Absolutely. I agree with you.
Yeah, I think for us, until our son got insight, and he only got insight once he was in a locked facility. I mean, because before that, he'd do the short stay at a hospital, 7 days, 10 days, the short, tweak the meds, get him out, put him into a residential, and he'd leave immediately. One, he didn't like the people there. He thought they were, not like him, or it was in
Right.
bad areas. They were in
Right.
violent areas. He was scared of the neighborhoods. It was awful. I mean, drugs being dealt right in the complexes.
Right.
And for someone that's not been brought up in there, they were naive. They learn fast, and we didn't think it went really well. We thought that a lot of the housing was subpar and dangerous areas. I mean, we do have some providers in town that do a great job, and they do the housing first model. One of them is the Copa Lighthouse, where they don't try to kick people out for breaking a rule. We said, don't smoke in the backyard, only in the front yard, or make sure you do this.
Yeah.
We do have providers that get it, and they try to work with people that are ill.
Yeah. I see a couple of other questions in the chat. If it's okay, I'll just try and answer them quickly. What do you think of the Build for Zero approach? I'm not, I'm a little bit familiar with it. I know it's kind of, they try and quantify and have a by name list, and it's fine. It doesn't, I think it's especially good for communities that don't know what they're doing and need that organization. it doesn't actually add any resources to the table and doesn't really change the way providers practice, so I don't know. And also there's not been one paper that shows that communities that participate do any better than communities that don't, so there's, in terms of an evidence-based, I don't know that there is one. So if you have a community where your continuum of care is on top of things and you know who you want to house, it seems redundant. And for me, it's like I would rather have what Milwaukee does, like have an outreach team go and actually meet the person to make sure they're eligible for this program, rather than rely on an assessment and a coordinated entry and a this and then, and people are like, as if you can hand people off like packages. That's not a good clinical practice as far as I'm concerned. Do you have any suggestions on how to build the staffing capacity, including the philosophy, to deliver this kind of model? This is what I spend my days doing. I think you have a conversation like this. So, people say, okay, this is a good model. We're going to try and do that. But where the rubber hits the road is you have to develop a community of practice. Those providers that sign up to do a housing first approach. And then you have like you have in any clinic that's well run, you have a case conference and you talk about individual people and what's happening and what's challenging. And that's when the staff actually learn to apply these principles that we're talking about to the actual work they're doing with clients. So you need both the kind of the training, like this is what the model is and these are the principles. And then you really need what I would call the implementation support, the ongoing, case by case discussion of the challenging cases, so that the team learns how to hold the principles and apply them in practice. And
Can you hire? I mean, how do you hire and test for empathy when you're going through hiring case managers or behavioral techs that are, they can make more at Starbucks. So
right.
it's hard.
It is hard, but you're right, Lori, that it's not the skills, because I think we can teach the skills. It's the values, and I think that we certainly don't pay enough in terms of the casework that and the demands, personal that are put on people to do this kind of work. But that's look, this is the thing. It's about our values. It's about our values. But people do show up there. A lot of people. Some people come and stay a long time, and other people do it almost like, after undergrad and before either a law school or a social work school or something, kind of like that. You don't have to go anymore overseas to do, AmeriCorps. You could do AmeriCorps in America, because there's plenty of people that need it,
That's a good point. Other comments or suggestions from others on the call?
This is a quick question. This is David Bridge from Access. Do you have any, you mentioned, again, dual diagnosis or comorbidities. Is there any additional layers of service beyond ACT, like for some of those substance abuse issues or treat? I know we want like low barrier, and we're not conditioning sobriety as a condition of housing, but is there any programmatic elements as part of that ACT team, or special strategies for people with the acute substance abuse issues as well as the mental health?
Well, I mean, I think that the ACT team with a substance abuse specialist is a good model. I think having peers on the ACT team is also a good model. People in recovery themselves, I think, is a very, we were talking about how do you hire people with empathy, Laura, you were just asking, but I think the inclusion of people with lived experience as full-time staff is sometimes, because that's the person that's going to go to the AA meeting or encourage that kind of natural support for that. But the current, the fentanyl, the opioid, the epidemic is killing a lot of people. And so I think we've had to also ramp up, just the emergency knowledge and response of the teams just to be able to respond in that emergent way. But it's, why I like the interdisciplinary team is that at least there we have a shot at addressing the addiction, because if you go somewhere where it's just like a mental health program, people get kicked out because they have an addiction problem, and you know how it goes, and get kicked out of the other one because they have a mental health problem. So at least this way we have the resources and people are making house calls, and I think the frequency of contact is also a very important variable there. Someone's in an acute state of use. We see them a lot. If they are using up their rent money, we would move to maybe even a conservatorship, like so that at least their rent would be paid, and try and manage their money so that they're not going to get evicted because of the extremes of use.
Thank you.
Any other questions? Yeah, I think this explains a lot. We've seen some really good models of this, but I think that for a lot of people, if they have no insight, zero insight, and they're psychotic, they need a little bit more work. Mike, I saw you. Do you have a question or comment?
Well, yeah, this is Mike Franzak from Copa Health. I wanted to mention that Dr. Tsemberis worked with us in Arizona for 5 years on a SAMHSA grant, where we had peer supports doing exactly kind of what he's saying. And we had an 87% retention rate for very challenged people. I think what's happened, Dr. Tsemberis had mentioned, is housing first has become just a term people use, but do not follow any fidelity and do not provide the support the person needs to succeed. So the model works very well when it's run properly.
Thank you. What do you think if someone is a real challenge with either emotion or addiction, and say they're on an ACT team and they live in wherever they're living? What do you think about having them have a one-on-one peer with them all the time for a period of time?
Yeah, I mean, if that's what would be useful, and that's what the person wants, and that's available, absolutely. I think one of the you alluded to this, Lori, about this model. The challenge of this model of the scattered site apartment, the pluses are people love to live like in normal settings and to have all of that independence. The downside is it's not a program that has a lot of structure, and some people need a lot more help in like looking at that calendar, and there's nothing on their calendar that day, and so what you're suggesting, either a peer with them that day or a place to go to, or like positive activities, positive engaging activities of their own choosing, is, I would say, the most challenging thing. This stuff that we talked about, mostly about getting people housed and all of that, that's actually easy. This stuff, putting a life together of meaning after the person is housed, and there's no longer that like emergency thing, like what are we going to do now? That is actually the hardest part of the program, and the one that often gets the least amount of attention, but the one that needs the most.
Is that how Portugal solves a lot of their heroin addiction? I mean, they stopped shaming the addict, and I'm
Yeah.
sure that there was a percentage of people with mental illness there also, and
Yeah.
they helped them build a life. They just said, "Why don't you come in and we'll give you needles and we'll give
Yes.
you a room and we'll have a
Yes.
nurse, and then
Yes.
can you not shoot up every day? Can you maybe shoot up 3 times a week? Can you go
Yeah.
to pills?"
Yeah.
And I
Yes.
think they had 90% of the people stopped using within 3 years.
Yeah.
Yeah.
No, it's remarkable. Complete decriminalization of all drugs. It's fantastic, really. It just, and that's why, like, well, what about that? Well, it's happened in Portugal, but it's like, why can't it happen here? We can, like, it is possible.
Okay, any final questions? Anyone?
Okay. Well, thanks very much for inviting me. It was a pleasure
Thank
to
you.
meet you and talk with you. So have a good evening.
Thank you. And I'm glad that you were able to explain what it really is and what it really isn't. I think there were a lot of great tips. I will have the recording up on the site. If you can send me a copy of your slides, some people will throw them in a PDF, and that way, if they want to see the screens.
Sure.
That's
Happy
helpful
to do
for me.
that.
Thank you. Have a great night. We really appreciate you.
Thank you.
Thanks.
You all.